Dear students, welcome back in Pathology lectures. Today we are going to study lung infections. This is Dr. Shaima Abdurraouf, lecturer of Pathology. What's meant by pneumonia? Pneumonia is infectious lung disease leading to infection of the lung parenchyma, causing consolidation or solidification of the lung tissue. This occurs due to presence of inflammatory exudate in the alveoli, changing the lung from its spongy consistency into more solid consistency. What are the conditions that favor pulmonary infection causing pneumonia? Exposure to contaminated air or aspiration of nasopharyngeal flora during sleep. Other lung diseases and diseases causing decreased patient immune response like congestive heart failure, COPD, and diabetes mellitus, all these diseases decrease the immunity. Lowering of the immunity of the host as a general cause like decrease in innate immune response as in complement defects or humoral immune response defect. Local causes like impairment of defense mechanism. Smoking causing impairment of the mucociliary clearance and macrophage dysfunction. Alcohol consumption causes loss of the cough reflex and interferes with neutrophilic chemotaxis. Pneumonia is classified according to its anatomical position, like lobar, bronchopneumonia, or interstitial pneumonia, according to the nature of the host reaction, fibrinopurulent, mononuclear interstitial response, granulomatous reaction, or necrotizing pneumonia. Etiological agents as bacterial pneumonia, viral pneumonia, or fungal, or etc. According to clinical setting, is it community acquired or nosocomial hospitalized patient acquired or immunocompromised host? Community acquired acute pneumonia, either lobar pneumonia or bronchopneumonia, mostly bacterial in origin, but it can follow viral upper respiratory tract infection like post-COVID. Streptococcal pneumonia is the most common one causing pneumonia. Aspiration of the pharyngeal flora is the most common cause precipitating to the pneumonic response. 20% of adults harbor staphylococcal pneumonia in the throat, so aspiration of the pharyngeal contents or pharyngeal flora causing that disease. Two patterns of acquired pneumonia, either lobar or bronchopneumonia. What are the predisposing factors that cause streptococcal pneumonia infection? First, chronic diseases like congestive heart failure, COPD, or diabetes mellitus increase patient liability to get infections more common than other patients. Congenital or acquired immune deficiency diseases, decrease or absent splenic function. Why after splenectomy this lesion can occur? Because spleen is a major organ responsible for removing of the pneumococci from the blood during bacteremia by its phagocytic effect and also producing antibodies against the polysaccharides of the encapsulated bacteria. Our first case is a 40-year-old previously healthy male. Complained of fever, chills, cough with minimal sputum production. On history taking, he admitted that he was extremely fatigued for the last 2 weeks. Our second scenario is an older patient, 70-year-old male, had undergone hip replacement and stayed in hospital for 15 days. He was a bedridden patient. Okay. Before departure from the hospital, he suddenly complained of fever, cough, and chest pain. What is the difference between the two scenarios? First case had that consolidation in X-ray. That consolidation take the middle lobe, the whole middle lobe showing opacity. The black color in the lung is a healthy lung containing air, while that white patch affecting the whole middle lobe is a diseased lung. In the second case, the 70-year-old male, there is multiple bilateral basal lung opacities. Opacities meaning that white shadows. Okay. First case, acute lobar pneumonia affecting middle lobe, while the other case is bronchopneumonia. It's a bilateral basal patches of opacities. Okay, the difference between the two cases, the whole lobe is affected, showing consolidation or solidified lung tissue, while the other case showing multiple patches of consolidation all over the lung and more basally. Our first case was acute lobar pneumonia. It's acute bacterial infection producing consolidation of the portion of lobe, large portion, or the entire lobe of the lung. Before the era of antibiotic, it evolves in 4 stages. First stage is stage of congestion. Second stage is called red hepatization. Third is called gray hepatization. Fourth stage is resolution. Hepatization, similar to liver inconsistency. Instead of being spongy, it becomes more solid like liver. Stages of acute lobar pneumonia starts with congestive stage. It occurs in the first 24 hours. Grossly, the affected lobe is red and heavy. Under microscope, from its name, there is congestion of the alveolar blood vessels, edema in the alveoli, alveolar walls, few red cells and few neutrophils. Later on, red hepatization occurs in the second and fourth day. There is red, firm, liver-like lung consistency. Under microscope, alveoli are filled with many red cells that give the red color, many neutrophils, no pus cells, okay, and fibrin threads. In the third stage, gray hepatization occurs in 4 to 8 days. The lung become grayish in color, not reddish anymore, grayish-brown in color, firm liver-like consistency also. There is fibrino-suppurative exudate, less red cells, macrophages begin to appear. Okay, resolution occur in the first week to the third week, resolution to the normal lung. There is absorption of the whole inflammatory exudate, macrophages predominate, neutrophils decrease markedly. Okay, stage of congestion, grossly, lung is heavy, dark and brownish in color. Alveolar wall are thickened, congested blood vessels with alveoli filled with edema, few neutrophils and scattered red cells. In red hepatization, the affected lobe is more brownish, reddish to brown in color, firm, heavy, airless, containing edema fluid, the whole alveoli no air, but replaced by edema fluid and fibrin exudate. Okay, under microscope, alveoli filled with inflammatory exudate, rich in neutrophils, red cells, fibrin threads with alveolar walls are thickened, congested, and edematous. Okay, again, alveoli are filled with inflammatory exudate rich in neutrophils, RBCs, fibrin threads, alveolar walls are thickened and congested. What about the covering pleura? There is marked thickening of the covering pleura. That marked thickening causing what is called fibrinous pleurisy. There is congestion of the blood vessels with marked deposition of fibrin threads in the pleural membrane. Okay, gray stage of gray hepatization that affects the lobe become more dry, gray and firm, heavy also. Become grayish because there is no more excess red cells inside the exudate. Okay, under microscope, stage of gray hepatization, macrophage begin to appear. Alveoli are filled with fibrin threads with neutrophils with very little red cells. Okay, alveolar wall are thickened with slight fibrosis. Stage of resolution, restoration of the normal condition, macrophages predominate with little neutrophils. Enzymatic digestion of the alveolar inflammatory exudate start to occur, and the fluid becomes semi-fluid with debris. Okay, that products can be coughed up or resorbed by the lymphatics, and the lung become again like normal lung. What about the pleural reaction? It also resolves when there is a minimal fibrin deposition, or it may undergo fibrosis and organization, causing fibrous thickening and adhesions of the covering pleura. It's also a complication. Okay, what about that X-ray? There is multiple bilateral patchy opacities affecting both lobes, both lung sides, or basal in position. It's a bronchopneumonia, patchy consolidation affecting both lung lobes. Okay. Bronchopneumonia is patchy consolidation. It's a suppurative inflammation, while lobar pneumonia, it was a fibrinous or serofibrinous inflammatory process. Okay, in bronchopneumonia there is suppuration, suppurative inflammatory reaction. It starts in extremes of age, children or old age. Okay, starting in bronchi and bronchioles and spread to the adjacent lung tissue and alveoli. Usually bilateral, more basal because the effect of gravity on secretion stasis. Okay, bronchopneumonia, grossly, there is multiple patches of consolidation in one or several lobes, variable in size. It ranges from 3 to 4 cm in diameter, frequently bilateral and basal, because of the tendency of secretion with gravity to become in the lower lobes. Slightly elevated, dry, granular consistency with grayish red and yellow foci. Why there is yellow foci? Yes, because there is suppuration, suppurative inflammation. There is multiple variable sized pneumonic consolidation, more basally, causing the lung to be congested, lung tissue in between. It's yellow in color, multiple variable sized. Okay, under microscope there is florid inflammatory reaction with excess neutrophils and pus cells. There is suppuration involving the bronchi and bronchioles with spreading